We know in science the mere act of observation can change things. And in the case of public reporting, when what's being observed is the medical profession, we know that can change too. So I'm talking to Dr. Robert Yeh, who is co-director of the Massachusetts General Hospital's Chronic Total Occlusion Intervention Program and associate director of Mass Gen's Cardiac Intensive Care Unit, and very recently, after the DAP trial, medical director of trial design at the Harvard Clinical Research Institute. First off, congratulations on that. But let's talk a little bit about association between public reporting of outcomes with procedural management and mortality for patients with acute MI. This is coming in the March 24th issue of JACC. Public reporting, it does change things, doesn't it?
I think that we think it does. The intent of public reporting is really to improve outcomes in patients who receive coronary intervention. And in 3 states now in the country, we have public reporting for PCI-related hospital-based outcomes for mortality. The goal is to improve outcomes, but there are, of course, unintended consequences potentially of any policy. And here what we examined was whether or not public reporting reduced incentives for patients who are high risk for having bad outcomes, prevented them from receiving PCI, and then ultimately looking at whether or not it influenced the overall outcomes of patients who presented to hospitals with myocardial infarction.
So what are the groups you looked at?
We used a database called the Nationwide Inpatient Sample, and we looked at patients who had hospitalization for myocardial infarction in states with public reporting, New York and Massachusetts specifically, and we compared them to patients who presented with myocardial infarctions in states without public reporting. The outcomes we looked at were whether or not patients in Massachusetts and New York were less likely to receive PCI when they presented with myocardial infarction, and that's indeed what we found. They were less likely to receive therapy, which we know is usually an indicated therapy. In addition, that effect was the strongest in those patients who were presented with the highest risk, those patients who presented with cardiogenic shock, with cardiac arrest. Those are just the type of patients we might expect to benefit the most from intensive therapy, and they received it the least in the public reporting states. We think that is potentially a symptom of risk aversion. So, we know that physicians feel like they're under the gun. Hospitals are under the gun with public reporting. What they don't want is to have a bad outcome. And when you see a patient come in, I think that there is subconsciously or even consciously a decision that, boy, this patient might not do well if I take him to the catheterization laboratory, and me or my hospital, we might be on the hook for that. And so somehow or other, we think it does influence whether or not those patients get taken to the cath lab for procedures.
Knowing that, what can we do?
Well, there was some thought that perhaps those patients who weren't getting taken were patients who really shouldn't be taken to the cardiac cath lab because maybe those were patients who wouldn't actually benefit. The procedure was futile. I think what we found was that actually the mortality overall in the MI population was worse, and that suggests that maybe those patients would have benefited. Otherwise, how would they have worse outcomes overall in the population? So what we really need to do is think about both the intended and unintended consequences of public reporting. First of all, we need to understand why physicians feel that the procedures for risk adjustment are inadequate to account for the risk that they're taking on when they take on a high-risk patient. We're doing that actively in Massachusetts, trying to work with interventionalists and policymakers together to figure out how we can better construct risk adjustment procedures that give physicians more faith in the risk adjustment so that they won't act on this risk-averse behavior. The second thing is we need to consider whether or not the patients at the highest risk should really be included in that metric at all. And there are some states, New York, for example, which have excluded the highest risk patients. We haven't done that in Massachusetts yet, but we've done other things to accommodate for it. This is going to be a continually iterative process. I don't think we're suggesting that public reporting should go away. It won't go away, but we need to refine it better to prevent harms from potentially being incurred by patients.
And is there any way of comparing across the different states to see how they calculate risk?
Yeah, absolutely.
Changes outcomes or what's reported?
It's a great question. Right now we really only have the 3 states, Washington, New York, and Massachusetts to work with. So we really have 3 policies to compare, and Washington is very new for public reporting. So really we've just got 2. But what we do have is changes over time in the way we report within the states. So Massachusetts has changed the way we report public reporting. In one step, we introduced new variables. What we'd like to do now is study whether or not that change influenced a change in risk-averse behavior. The same in New York. They used to include cardiogenic shock patients and STEMI patients. Those have systematically now been excluded, cardiac arrest patients. And so the question is whether or not that change in policy has actually improved the risk-averse behavior. We didn't study that in this study, but that is next on our list.
Well, the paper is a great one, and it's in the March 24th, 2015 issue of JACC, so please check out Yeh and colleagues. And for Cardial Source World News, where I'm Executive Editor Rick McGuire.